Hi everyone, my name is Dr. Preeti and we'll be discussing today about the general gynecology module, and the topic today what I'm going to discuss is heavy menstrual bleeding. So just starting with a small quote that make your dreams come true. So to make your dreams come true, you have to work a little harder and be consistent till your exam. So it is an RRR series for the general gynecology module, and the topic is the heavy menstrual bleeding. So heavy menstrual bleeding, by definition, I can say that NICE has a very nice definition which tells us that what is HMB. So HMB by definition is excessive menstrual loss which causes an impact on the quality of life, or there is sanitary pads or products changed every 1 to 2 hourly, or there are menses which last for more than 7 days. So heavy periods that last longer than 7 days, there is a every hour or every 2 hourly, there is a change of products required. Need to wear multiple pads at one time because just to prevent leak. Changing of the pads in the middle of the night, cannot do normal activity that is affecting the quality of life. Passage of cloths which are size of a quarter or larger several times per day. So this forms the definition of HMB according to the NICE. So if they ask you, according to NICE, what is considered heavy bleeding? Bleeding in menses that lasts for more than 5 days. No, it should be more than 7 days. Menstrual loss, which is associated with symptoms of excessive blood loss. This is actually not a complete definition. Loss that causes sanitary products change every 3 to 4 hours. No, it is 1 to 2 hours. Bleeding in menses which lasts for more than 7 days can be one of the correct options. And menstrual loss where products are changed more than 4 times per day. It is actually several times a day because the changing is required every 1 to 2 hourly is a heavy bleeding. So according to what ruling out all the options, the correct option basically is menstrual loss which lasts for more than 7 days. So the classification of AUB says that there can be a palm coin classification, where the palm stands for the structural defects and the coin is pathology other than structural defect. So palm is basically polyp, adenomyosis, leiomyoma, malignancy or hyperplasia. Coin is basically not a structural defects, so like coagulopathy, ovulatory dysfunctioning, endometrial causes, iatrogenic and not otherwise observed or classified. Heavy bleeding is if the patient has only symptom of HMB with no other complaint, like there is no complaint of pain, there is no complaint of intermenstrual bleed, there is no complaint of postcoital bleed, and there is no complaint of any heaviness lower abdomen. Then if only HMB is a presentation with no other symptoms, you can give directly this patient the management, that is LNG-IUS. Definitely, investigations are not required and examination is also not required. But before inserting LNG-IUS, you need to do a physical examination. But investigations are usually not required if you consider that the patient is definitely a full blood count is 100% required. Without that, we will not know how much blood she has left and maybe she is severely anemic. But for cause diagnosis, we do not do any investigation if only HMB is the presentation without any other symptom. So you can start with LNG-IUS, which is the first line of treatment. Some patients in whom HMB is associated with other symptoms, or if you are planning to introduce LNG-IUS or before any investigations, you can do a physical examination. If in patient of HMB, there is a history of pelvic mass, she presents with the pressure symptoms, abdomen is palpable, examination is inconclusive or difficult because of obesity. If there is associated symptoms like severe dysmenorrhea where you suspect it can be endometriosis or adenomyosis, so in these cases, transvaginal ultrasound should be done before offering them any type of treatment. Some patients will require hysteroscopic guided biopsy. This is always a not a blind biopsy. It is always an outpatient hysteroscopic guided biopsy. And the group of patients in HMB which require this management, this investigation before offering them any treatment is any patient with the persistent intermenstrual or persistent irregular bleeding, which women has HMB with the risk factors of endometrial cancer or endometrial hyperplasia like PCOS, obesity. She is on tamoxifen with HMB. She is suffering from HMB where the treatment was offered, but it was unsuccessful. Or if the history suggests that there can be a submucosal fibroid, polyp, or endometrial pathology. So in these patients, before offering them any management, you need to do a hysteroscopic, outpatient hysteroscopic guided biopsy. No blind biopsies are done in these patients. Now, talking about the management, if HMB is the only symptom, or if the HMB is because of any fibroid, which is less than 3 centimeters and not obstructing the endometrial cavity, or if the HMB is related with the suspected or diagnosed adenomyosis, you can offer these patients LNG-IUS as a first line of management. Second choice is Trenexa, NSAIDs or Ocipils, and third choice is progesterone. First line management LNG-IUS may take 6 cycles to adjust, because sometimes in first 6 months when you give LNG-IUS, there may be some irregular bleeding which the patient may suffer. So you have to counsel the patient that it may take 6 cycles to see the benefits. Now, if any treatment you have given to the patient and it is unsuccessful, she is not responding, so you can change from one treatment to another treatment, one pharmacological management to another, or if the symptoms are severe, these patients may require the specialist review, where the investigation and alternative treatment options will be given. So if the treatment, all the pharmacological management options have been given, or if the patients have so severe symptoms that even after one pharmacological management, she is not responding, there are options for the surgical management, where if there is no other pathology and there is a clear endometrial cavity, ablation can be done. Hysterectomy can be planned. If there are fibroids removal can be planned. So there are various drugs which I have just told you, like LNG-IUS, tranexamic acid, NSAIDs, Ocipils, progesterone. Injectable or implant progesterones can also be used, or GnRH analogs. So these all drugs can be used as a pharmacological management of HMB. Among them, the best results are obtained by LNG-IUS system. How much blood loss they stop? So you can see in the table that blood loss is reduced by 95% in LNG-IUS users, 58% in tranexamic acid users, and 25% in NSAIDs, approximately same, 50%, 43% in Ocipils, and progesterone, oral progesterone reduces the blood loss by 83%. Even the GnRH has high ability to reduce the blood loss by 89%. But everybody has their own restrictions of use. So you have to make sure that depending upon their side effects and contraindications for the patient for use them, you have to offer the medical management. As I told you, if medical management is not affecting, not helping the patient, and it is a clear cavity where the endometrial biopsy has been done and there is no hyperplasia, no cancer, then ablations can also be done. Making sure that whenever ablation is done, the endometrial cavity is clear. It is not, there is no growth there, no other abnormality which is obstructing the endometrial cavity. Some fibroids, if they are less than 3 centimeters and not causing any harm, any distortion of the endometrial cavity, there also endometrial ablation can be the process which can be done. So it has some selection criteria that uterus should be no larger than 10 weeks. Family should be completed. Patient, because it is just a procedure where you can solve the problem of HMB, it is not contraceptive. So patient should be willing to continue contraception if not sterilized. Patient should have tried some medical management which has failed. Normal size, as I told you, cavity should be okay. And patient should be willing to undergo hysterectomy if required. And there are certain contraindications which you have to make sure you understand that any patient who wishes fertility, it is an absolute contraindication for ablation. Apart from that, undiagnosed bleeding and infections are the other reasons. And any uterine cavity length more than 12 centimeters is also something, or fibroids more than 3 centimeters, even if they are submucous. if they are indenting the endometrial cavity are the contraindications for ablation. Now, there are two varieties of endometrial ablation, first generation and second generation. Nowadays, second generation endometrial ablation is the preferred procedure because it is more cost effective, done as an OPD procedure without any anesthesia, has fewer complications. So as compared to first generation, second generation are preferred. So among the two generations of contraceptives, endometrial ablation methods which are available, so among them, the success rate is highest. In the first generation, the highest satisfaction rate you can see over here is with the roller ball. And second generation, the highest satisfaction rate is with the NovaSure. Okay, so these are few things which you should know. And common complication with first generation is hemorrhage and second generation is endometritis, which is something which should be known. Now, because fibroids are one of the reasons for HMB abnormal bleeding, so you have to make sure that you know the FIGO classification, because this is the classification which tells us whether the fibroid is submucosal, intramural or subserous, or it is a hybrid. So your treatment for fibroid will depend upon its classification. So you should know the classification and you should understand where is the fibroid. So ideally, if there are asymptomatic fibroids, we do not treat them. Okay, by chance, if by ultrasound it is diagnosed, we do not treat them. If there are symptomatic fibroids and their symptom mainly is a heavy bleeding, you can start with the medical management if the patient is okay. If surgery is avoided, in this case, if the pharmacological management is good, it is able to reduce the bleeding and the cavity is okay and there is control of bleeding by management, it is okay. You can consider it. However, if it is not helping, then surgical methods like conservative approach where you can retain the uterus is myomectomy or UAE or the MRG-FUS, which is a magnetic resonance ultrasound. Basically, it is something which is burning of the endometrial lining, which is done. Retaining the fertility, if the patient wants to preserve the uterus for fertility purpose, still not going for the absolute procedure, then myomectomy can be done. Aishwarya? Aishwarya?
Yes, ma'am.
My internet is showing it's unstable.
But we have no issue, ma'am. Your voice is perfect for us, ma'am.
Okay. I thought there is nobody there. Okay, I'll just, you can cut from the table. I'll just start from the table again, okay?
Okay, ma'am.
Yeah. So fibroids management is basically when they are symptomatic. Asymptomatic fibroids are not treated. So symptomatic fibroids treatment can be a medical management. Usually it is a short-term treatment because usually the fibroids are not treatable by the medical management. Only to control bleeding, reduce the uterine volume or restoring the uterine cavity, there can be, as a pre-operative, you can use it for some patients who are awaiting surgery or if they are near to menopause. Okay, so mainly these are the two indications where they use it. Or very rarely, if the patient is very sick and you want to avoid the surgery. If that is helping the patient, it is good. Surgery can be avoided. However, if it is not helping, then surgical management where you can, if it is the fertility is not an issue, okay, and the patient has completed family. So non-conservative approach like hysterectomy is there. If the patient wants a conservative approach, so if the patient wants to retain the uterus, but she does not want pregnancies further, okay, then uterine artery embolization or myomectomy can be done. Now, only procedure where you want the patient wants to retain uterus for fertility purpose, you have only the option of myomectomy. Okay, please remember, UAE is not given as an option if the patient wants to have children in future. So, various medical managements which are available are NSAIDs, tranexamic acid, COCs, LNG, IUS, GnRH analogs, or sperms, selective progesterone receptor modulators. So UPA, that is ulipristal acetate, is one of the drugs which is used in European countries, which is used as an effective treatment of your HMB in the patients who have fibroids of 3 to 10 centimeters. But again, it causes liver dysfunctioning. So you have to be little cautious. It does not mean that you do not use it, but you use it. Now it is licensed for use fully. What you need to do is, before you start, you have to do a LFT check. Okay. Now you will give the UPA 5 milligram tablet once daily for 3 months. At the start, you will do a liver functioning test. Okay. Now, in between, you have to give a treatment-free interval of 8 weeks. So, and you can give the second course. And for the first 2 courses, when you start, again, for the 3 months, you can give after an interval of 8 weeks. So for the first 2 courses, when you start, you have to make sure that liver function test should be done. Most common side effects seen with the 67 to 70% fibroid volume reduction is seen with this. And within 7 days, the bleeding is controlled. Surgical management is usually done in the patients who have severe pressure symptoms, unresponsive to medical therapies. They have pedunculated serous, subserosal or submucosal fibroids. As I told you, if fertility is not a concern, then and the patient has completed the family and the patient has reached the age where removing the uterus will be okay, then you can opt for hysterectomy. If fertility concern is there, patient wants to retain the uterus for fertility purpose, then myomectomy. If the patient wants to retain the uterus, then but fertility is not an issue, then minimal invasive UAE can also be planned. But for these patients who have completed their family and are near to the age of menopause, hysterectomy can be done, whether in open, whether in laparoscopic. Same myomectomy can be done either open, either laparoscopic or robotic, whatever is required. Now, myomectomy, because some fibroids are submucosal, some fibroids are intramural, some are subserosal. So, myomectomy can be done hysteroscopically guided if it is a submucosal fibroid, laparoscopic if it is a subserosal fibroid or intramural fibroid. So, depending upon the size, number, location, the myomectomy is planned. Making sure that you know, before you do any myomectomy, you have to make sure you know the exact number, exact location and size. So if it is required before doing even a hysteroscopic or laparoscopic myomectomy, MRI should be done because it is seen to be very useful. For submucosal fibroids, which are up to 4 centimeters, you can remove them in one go. Okay, by single, first time when you are doing a hysteroscopy, in the single procedure, you can remove. If they are 4 or more than 4 centimeters in size, usually it is difficult to remove it in one go. So multiple, you can take more than one session. And if the fibroid is more than 3 centimeters in size, then GnRH analogs can be used to reduce their size. And thereafter, basically it will reduce the bleeding and the blood loss. So it is good to give them. In any type of myomectomy, it should be a rule. And you can thereafter do the surgery, explaining the risk and complications. Laparoscopic myomectomy can be done for the subserosal or intramural fibroids. Depending, again, as I told you, MRI can be done for knowing the exact size, location also. And depending upon their location, fibroids up to 10 centimeters can be removed laparoscopically, as big as that. Definitely, complications and side effects are there, which you need to explain to the patient. Uterine artery embolization, it is a promising treatment for symptomatic fibroids in the females who are young, do not want to undergo the major surgery. Making sure here that the patient should understand that she will not conceive after UA, okay, because it is associated with a lot of problems. So if the patient wants to retain the uterus and wants a minimal procedure to be done for the fibroid, and she wants children in future, then UA should never be offered, okay. Fibroids more than 1 centimeter in size, not the uterus size should not be more than 24 weeks. Most common indication is hypermenorrhea or dysmenorrhea, bulk-related symptoms. Uterine artery embolization is contraindicated for cervical fibroids, unclear entity, severe contrast allergy, treatment, if the patient has taken treatment with GnRH agonist, basically it says that UAE is unsuccessful in them. Previous pelvic radiotherapy, immunosuppression, renal insufficiency, uncorrectable coagulopathy, etc. And MRI should be performed before UAE. So I can just brief that contraindications for indication for UAE is basically symptomatic fibroid. Either they do not want a major surgery or they're unfit for major surgery. If the fibroids is such big that major surgery can cause excessive blood loss requiring blood transfusion. So in patients who are Jehovah's Witness, you can do a UAE procedure. Contraindications are pregnancy, infection, doubtful diagnosis, who will never undergo hysterectomy because sometimes UAE is unsuccessful or may land up in risk of infection where hysterectomy has to be done. So if they are not willing for hysterectomy anytime, so UAE is never offered. Benefits, it has increased satisfaction rate, shorter hospital stay, uterus is saved. Problems, it requires a re-intervention sometime, it is costly. Pregnancy, if patient gets pregnant, problems are there with pregnancy. What commonly is used is right femoral site is used, and basically you go in from there to the uterine artery with a catheter size of 4 or 5. As I told you, the patient should not get pregnant, and if she's planning pregnancy, should not use the UAE as a procedure because it increases the risk of miscarriage, basically, and other problems like preterm delivery, cesarean section, malpresentation, abnormal placentation, or PPH can happen if the patient gets pregnant after undergoing UAE. So just to brief again that UAE is a procedure of choice for the females where they want, when they have a fibroid causing HMB, they want to retain the uterus and they are not planning pregnancy in future. If in any case patient is planning pregnancy, UAE is never offered, and the best surgical procedure where fertility, which gives the best evidence for fertility in future, the surgical procedure is myomectomy. Okay, so myomectomy should be the procedure of choice if the patient has HMB because of fibroids not responding to medical management. So let's see some questions. A 35-year-old para 2 presents with a heavy menstrual bleeding. Her cycles are regular. On examination, it is a normal size uterus. She had a trial of NSAIDs and tranexamic acid, and she has a family history of thromboembolism. What is the next option for her? Now you can see that one line of pharmacological management the patient has used, that is NSAIDs and tranexamic acid. Ideally, they are not first line. However, she is given that, but she is not responding to that. So we can offer her the LNG IUS here because that is a best first line management option. Then 35-year-old para 2 women, 35 BMI of 32, HMB is present, also complains of intermenstrual bleeding. Otherwise, cycles are regular. On examination, there is a normal size uterus. Hemoglobin is less. Cervical smears are normal. What is the next option? Now, heavy bleeding with the persistent intermenstrual bleeding puts a patient at risk of high BMI also, obese also, puts at risk of either they can be polyp, mucosal, submucosal fibroid, or there can be some endometrial hyperplasia changes. So in these patients, you will never offer them directly any management. First of all, you will do a hysteroscopic guided biopsy to rule out the problem. Then let's see the answer. So answer is hysteroscopic guided endometrial biopsy. Then 43 years old, menorrhagia for the last 2 years, completed her family, had a trial of pharmacological management which has not helped her. On ultrasound examination, 3 intramural fibroids are there. The uterus is 8 into 5, 6 into 5 centimeter, endometrial thickness is 6 mm. Biopsy was done, which was normal. She was given an option of UAE, but she refused. What is the next best option for her? Now, because she is a 43-year-old lady where the patient has already taken few medical management, uterus is not very big. Intramural fibroids which are present are very small, likely not indenting the endometrial cavity. Now, because her biopsy has been done, she is proved that there is no problem in biopsy. So these patients, you can offer endometrial ablation because she is quite young to undergo hysterectomy. In these patients, whenever you plan to do hysterectomy also, they will compromise the ovarian function, resulting in the type of surgical menopause. Okay. So every time these patients should always be given an option of something which is less invasive, less major. If that is not helping, or if they do not accept that, then definitely we can give the option of the major procedure. But here the better is to give her the option of endometrial ablation rather than directly going for hysterectomy. A 27-year-old suffers HMB on abdominal ultrasound. There is a 5 into 5 centimeter submucosal fibroid. She wishes to have a procedure that is the best evidence for future fertility. Now you can see, and medical management was done, that has nothing helped her. So you can understand that mucosal fibroid not responding to pharmacological management and wants a surgery. A removal of that fibroid is required, where the surgery gives the best evidence for fertility. So UAE can never be the option, because after UAE, the patient can't get pregnant. Definitely, we do not go for the major surgery like hysterectomy. But here, myomectomy is the best option. And because it is a submucosal fibroid, you can go for the hysteroscopic guided myomectomy. Lastly, 52 years old, most likely postmenopausal, might not be, 2 years history of dysmenorrhea and menorrhagia with pressure symptoms, has abdominal mass, 20-week size fibroid, multiple fibroids in uterus on ultrasound, hemoglobin is very low, tried medical management, nothing helped, suitable management for her. Now you can understand this patient has passed the age of menopause. She is already having multiple fibroids, bleeding so heavily that hemoglobin has come so low, and nothing else, whatever has been given to her, is helping her. So this patient basically falls in the category of GnRH followed by hysterectomy, because it is some procedure which is only going to help. And now here, multiple fibroids you can't remove, right? And such a big size fibroid, just going for the non-invasive UAE won't help her, because that is something which is offered to somebody who is young, where you want to retain the uterus as well as you do not want to remove the uterus, because removing of the uterus may compromise the ovarian functions. Okay. This patient already is the past postmenopausal age group. So you can give her a definitive management, that is GnRH. GnRH will actually buy time to reduce the size of fibroids, making sure intraoperative blood loss is less, and also will buy time for improving her hemoglobin. Okay. And followed by hysterectomy. I'm also going to discuss a very important heavy menstrual bleeding in adolescents, and something which came out in 2024. So any patient, any young girls, when present with a heavy menstrual bleeding, there can be variety of causes. Okay. And the most commonly they say the anovulatory cycles, which are related to the HPO cycle irregularity, is one of the major reasons. Okay. So you need to know what is the reason for the HMB. So you need to take a detailed clinical history of the menstrual history, menstrual cycles, associated symptoms, sexual history, if they are sexually active. You have to ask everything about the STIs and contraception. Bleeding history, like past medical history, like any chronic illness like liver problems or any bleeding history, where you can get an idea, okay, she may be somebody with VWD syndrome or factor deficiencies, etc. Any drug history, for example, if she's on some drug, she's using some contraception as well as she's using some drugs, like she's using some anti-epileptic drugs like carbamazepine, and the same time she's using CHCs. So their action is not good with each other. The drug interaction is there. So these patients may sometimes present with HMB. So that history is very important. Family history will give you an idea, okay, there is a bleeding disorders in the family. So that is why she's bleeding heavily. Or there is a history of some type of cancers or PCOS or endometriosis in family, social histories, maybe sometimes bullying and self-confidence. Basically, these are the reasons. HMB is one of the reasons for causing all this. So, but sexual assault is something which you need to explore over here. Then investigations, when they talk, they say, as we know that this is a general practice for the patients who are losing blood, FBC should be done, full blood count should be done. But for the young girls, they propose that ferritin level and coagulation screening with PT, APTT, and fibrinogen levels should also be checked. If you suspect that she is having some bleeding disorders, then von Willebrand disease screening and testing for the factor 8 should also be done. If she has symptomatology for thyroid, thyroid should be checked. Prolactin should be checked if the symptoms are there. If you suspect she has PCOS, then free androgen index should be checked. STI screening and pregnancy test should be done. Ultrasound should be done because ultrasound will rule out pelvic mass, any uterine anomalies, and it's actually it gives a little confidence to the patient and the attendant that, okay, there is no pathology, so ultrasound should be proposed and should be done, should be offered to all the females. Management, it is little different from the reproductive age group. Young girls, the first line of management is tranexamic acid. Okay, you can give throughout the 4 days and you can see whether they are responding or not, or you can give the ibuprofen. Mefenamic acid is avoided, but making sure you give them iron supplements, 2 to 3 divided doses, 100%. If they are not responding, hormonal preparations like COCs can be started. The combined hormonal pills can be started, or combined hormonal patch can be given. She is sexually active, then rings can be given. Desogestrel is among the progesterone variety. If in case she's having some contraindications for CHC, or she is having some problem with CHC and you want to start her on progesterone, then desogestrel, among all the POPs, desogestrel is the first line. Norethistron can be tried if desogestrel is not available or not responding, or medroxyprogesterone acetate can be given. Among norethistron and the MPA, they say that norethistron is associated with the risk of VTE. So if the patient is at any risk of VTE, don't give that, okay? Because it is metabolized to ethinyl estradiol in the blood, and estrogen is associated with the venous thromboembolism risk. LNG IUS can also be given because it is very effective. So, but for that case, you need to know that patient is sexually active, then you can give. If the patient is not sexually active, or if the patient is having some learning disabilities, then it requires a general anesthesia. So it carries a risk which you need to explain. And if the patient by chance has any problems with like arrhythmias or any other problem, then LNG IUS insertion will require cardiologist involvement. DMPA can be given, but again, its prolonged use is associated with irreversible osteopenia and higher weight gain. So you have to balance it before you give. And all these patients, whatever type of treatment you are giving them, medical review at 6 months is required after the hormonal therapy to these patients. In case if the patient present with the acute hemorrhage, the young girls are coming with the acute hemorrhage and acute heavy bleeding, you have to make sure that basically there are 2 pathways. First, she is hemodynamically stable or not. If she is hemodynamically stable, then you will take a clinical history, do examination, pregnancy test, full blood count, coagulation screening, abdominal and pelvic ultrasound. Pelvic ultrasound only for sexually active. Additional investigations as indicated, like which we have already seen. Okay, you'll offer her tranexamic acid. If there are no contraindications, iron will be given, oral iron, or if required, iron infusion. If this is not responding, then hormonal treatment can be started. Now here the most important point is, I told you in the reproductive age group females that CHCs are basically the drug of choice, always, okay? But remember, for the acute bleeding, always progesterone is ahead of CHCs. So here for hormonal treatment, you will start with the progesterone, medroxyprogesterone acetate you can give. Consider its long-term use, need for contraception, and HMB management. Discharge planning should be done according to the condition of the patient, and the management should depend upon how she discharges. She has to take the medical management as prescribed. Now, if the patient is hemodynamically unstable, she presents with a heavy flow during the menses. So you need to put 2 widebore cannula, take some blood tests, pregnancy test, crystalloid infusion. May she require the blood transfusion as well. So clinical history and examination is must. Alert the child safeguarding team and police if there is any doubt about the sexual assault. Acute anemia less than 8 gram hemoglobin or active bleeding with hemodynamically unstable condition despite of full fluid resuscitation is there. If this condition is not there, she is hemodynamically stable, then you can follow this path. If she is hemodynamically unstable despite of fluid resuscitation, you need to give her blood, platelet transfusion if platelets are less than 50. Clotting factors if there is a severe deficiency. Tranexamic acid 1 gram. Again, you will give her progesterone. Remember here CHC has less role. You will do an examination under anesthesia or ultrasound. Balloon tamponade can be tried with Foley's catheter if underlying bleeding disorder or hemodynamical compromise is not responding to the hormonal therapy. So this is something very new about the HMB in the adolescence age group. So now let's see two to three questions related to that. So if the 16-year-old lady is attained menarche at the age of 12 years, presents with the heavy bleeding, her periods are irregular, lasting for 8 to 9 days. What is the first choice? I told you that for young girls, the first choice for treatment is always a tranexamic acid. Okay, so this is something which is new. And also you have to know that whenever you are giving them for heavy bleeding, if you are giving them any type of hormonal management for heavy bleeding, acute hemodynamical condition, hemodynamic compromise is there, and you are planning to give some hormonal therapy, then in these patients, progesterone has to be started, okay, as a first line hormonal treatment. So guys, this is all from my side. I hope this helps everybody. It's a RRR series from Study Medic for EFOG Part 1 students. You can, even the other students can watch it and use it for your exams. So thank you so much. Have a nice day. And my name is Dr. Priti. I am mentor from Study Medic. Thank you so much. Yeah, Shwarya, I have done.